Let's see. I don't see my co-host. Okay, well, we gon' pray all is well. I know I reached out to him this week. They were having storms out there and power outages and all kinds of things, and so hopefully that hasn't impacted him and his abilities today. But you know us, we gonna move right along. I wanted to let y'all know, how I don't know if you I don't know if it's just on Facebook, but you can mark yourself safe from certain places. So I wanted to mark myself safe from Montgomery, Alabama, because that's where I was um last week. And yeah, I'm safe. I'm here. Even though when I go to Montgomery, I stay downtown. I'm steps from where the melee was. I was not there. We were actually, I think it was in the evening, so we were actually on our way home at that point. But yeah, I'm safe. But anyway, welcome everybody. Welcome to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, the weather, melees, foolishness, all the things, all the things. And of course, the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I am Clarice Warner. I am the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Well, before we get started, let me ask you, do you know what it takes to be a certified marketable is the key word here, medical coder? Well, if not, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
Oh, y'all know I love the music. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, and you are joining via YouTube, Facebook, or LinkedIn, check the video description. The link is there. I promise you. It's down there. I promise you. If you are on Clubhouse, you can feel free to click the link at the top of the page for more information. All right. So let's see. Before we jump in, let me remind you that you can join in and add to the conversation. So don't be shy. Your opinion matters and actually is welcomed here. This is a conversation. We bring the topics and we talk about them with you. So we encourage your conversation and participation. Some of y'all are jokesters and didn't know it. So it's great to have the interaction. Good morning. Good morning. Let's see. Good morning, Regina. Thank you for joining. Hey, Renita. Thank you for being here. I love it. You mentioned I think it was last week or was it the week before? You found your tribe, and we were so excited about. Yes, we found our tribe. We found our tribe. But anyway, if you have a question for me, just make sure you put a Q in front of it so I don't miss that it's an actual question for me versus us just having some conversation. So for those who are joining us or watching the replay, today we are talking about ICD 11, clinical modification or nah. Yeah, it's there's a lot of conversation in these streets about ICD 11, even though it's already up and running. And several countries. But for the US, we special and we have to do things our own little special way. So we'll talk a little bit about some of the discussions that are being held regarding that. But before I get to that, let's go into our church announcements. Church announcements. Yeah, my co-host is gonna miss the surprise. I told him last week I had something special for him. He's gonna have to watch the replay to see what's special. This is what I had. We had our church band, the old school Martin Luther King church band. Ours has a little twist. And our Saturday morning tea here. I know I like to play, so here we are with the church band. Our church announcements. Okay, so our church announcements for today, let me see. Music. Okay, church announcement for today. I got two. The first one is the coordination, the ICD-10, because we're still in ICD-10, coordination and maintenance committee meeting is coming up in September 12th and 13th. It's a 2-day event starting at 9 a.m. on each day. I think it lasts till about, well, depending on the conversation, the topics, I think they have it slated to last till like 4:30 Eastern time. You can, in order to attend, and it's in person and it's live, I believe. I know it's on a webinar. I believe they also have it where they're making it live. Maybe not. Maybe it's just all webinar. But anyway, in order to join, it's free and open to the public. You have to register. I'm just giving you the information. I will put a registration link. I think I'll put the registration link with the in the description where I list all of the references for the day. So I'll put the registration link if you're interested. And again, this is where they provide information about new ICD-10 CM codes for not this cycle. I think these are the ones that are for April. And they also provide information on the PCS codes. And when I say information, they give you the what the codes are and the description of the codes, but then they go more in depth. And so for people who were interested in having these codes added to these the manuals, they provide a presentation on why and specifically with procedures, like what the actual procedure is. It's generally providers providing that information about the procedures and the impact and effects of those procedures. And then with the diagnosis codes, sometimes you have providers, but then you have other clinical professionals, researchers, et cetera, who will bring information about some of the diagnoses that they found. And then if it's not necessarily a diagnosis, but it's something related to, you can have Z codes and you can have other types of codes in ICD-10, then you have other people who will also bring that information and the background around that. So this is just more in depth. You also get CEUs. So if those folks who are looking for free CEUs, here is an opportunity to get your CEUs as well. So that's one church announcement. The other church announcement is on August 1st. I know I'm a little late, but in case you didn't know, the Inpatient Prospective Payment System, or IPPS, and Long-Term Care Hospital Prospective Payment System, LTCH-PPS, issued their final rule for 2024. I will probably break this down in a long form video and post it here on the channel. But I wanted to let you know one little special thing that has come about as a result of the final rule. And that is with the health equity. So the rule advances one of the goals of CMS framework for health equity, which is 2022 through 2023. You know, they like to have these 10-year kind of frameworks happening to more explicitly measure the impact of their policies on health equity. As part of our growing capabilities in this area, they are adding 15 new health equity hospital categorizations for the fiscal year 2024 IPPS payment impacts. So moving forward, one of the priorities of the CMS framework for health equity 2022 through 2032 is to expand the collection, reporting, and analysis of standardized health equity data. And as additional data becomes available, they plan to incorporate it on an ongoing basis into their impact analysis. So what that means is that they will be collecting information. They're adding kind of another measure around health equity for hospitals. And so, you know, the better the hospital does in this area, the a reward of some sort does usually follow. So just wanted to share with you that information. But yes, it is out. You can find information about the 2024 IPPS final rule on CMS's website. Okay, I think that is it for our church announcements. Let's see. Comments. Good morning, Vicky. Good morning. Good morning, the Crafty Coder. Good morning, everybody. Thank you for joining. Okay, so today we want to talk a little bit about ICD 11, clinical modification, or not. Or not. So I briefly talked about this meeting last week. And I promised to do a summary of what was happening and what was going on. So let me see if I could share my screen here so you can see the information. Okay. Okay. So the National Committee on Vital and Health Statistics, one of the cooperating parties of ICD, all of them, just ICD, put together this work group, and they've been meeting for a while, at least a year, discussing ICD 11 and what we should do in the US around implementation and policies related to that. So again, they had this meeting that was open to the public from the work group a couple weeks ago. And here's some information. So ICD 11 was adopted by the World Health Organization in 2019. Y'all know it's 2023, right? Okay. It became effective beginning 2022. The three components that they considered or needs to be considered: mortality. U.S. adoption is a requirement of membership in the World Health Organization. Morbidity for U.S. healthcare and public health, and morbidity for U.S. healthcare billing and payment. The U.S. adoption would have to be a HIPAA-mandated medical code set, which all of our ICD-10 is HIPAA-mandated code set. Some of the previous activities. So, like I said, they've been meeting. Oh, actually, I guess they met prior to that. They started in August 2019. They had the expert roundtable meeting in November. They were evaluating the impact of the different approaches to the transition and implementation of ICD-11 in the US for mortality and morbidity classifications to guide policy and decision making, and also wanted to provide timely leadership on strategic outreach and communication to the US healthcare industry about the transition to ICD-11. So they've been sprinkling some things, letting folks know that it's here, it's out, and we really need to get on the ball. So they also in 2021 recommended to conduct research to evaluate the impact of different approaches to the transition to and implementation of ICD-11, conduct outreach and communicate regularly to the U.S. healthcare industry about the transition. Their overarching goal is to craft recommendations to inform development of sound U.S. policy for the transition to and implementation of ICD-11. Let's see. Develop advice and recommendations to HHS regarding adoption and implementation of ICD-11. Avoid a protracted and costly U.S. transition by developing a shared understanding of lessons learned from the ICD-10 transition and the differences between ICD-10 and ICD-11. They wanted to conduct research to inform a relatively smooth transition, identify work needed to avoid the need for a full clinical modification. So this is where kind of the eyebrows went up, and it's understanding. And I think I talked about this before, where they're really considering whether or not a clinical modification is necessary. And then identify key topics and messages to communicate to the industry to foster early stakeholder engagement and preparation for the transition to ICD-11. And so that is how the meeting started, how we got everything got the ball rolling. And I'm sorry, I left your comments up there. That's how we got the ball rolling. And yeah, that was part of those discussions. Well, I don't know if you know or not, but they also had a request for information. I think I shared that. There was a request for information from healthcare entities and organizations. There were, I think, 12 questions that they were asking folks to consider when thinking about the various processes, policies, tactics to implement ICD-11. There was a lot of pushback. It took 23 years to get ICD-10, and I think they don't want it to take another 23 years to get to ICD-11. And so it's like, well, what can we do different? What are the learnings from that? And so the work groups, or the members of the work group, and there's several of them, they broke them down into like 8 specific groups, but they also touched on the request for information. And so I'll bring that slide up for you as well, so you can see what some of the thought processes, and you can consider, because I think there's they're considering another request for information to ask folks to chime in and weigh in on what their thoughts are, because they're looking to engage all stakeholders, and by all stakeholders, it's not just the big organizations, but it's all the way down to the person who actually uses these codes and the manuals. That would be us. That would be you. So you have a voice, and you can feel free to use that voice. Use that voice in this. Okay, I'm not finding, what did I do with my slide? Okay, here it is. All right, let me open this up so you can see. Hope everybody is doing well this morning. Y'all quiet today. Any thoughts? I know I don't have my sidekick here who would normally give all kinds of thoughts, but any thoughts? Remember, conversation. We're here. Use your chat. Okay. Okay. Let's see. Can I do? Yeah, I'll do it this way. All right. Change up a little bit. Okay. So this was the information provided on the request for information. And so here are the results. And they looked at all of the results that people turned in. They broke them down. And so initially, here are the questions. Here are the 12 questions. What would be the benefits? What would be the benefits of implementing ICD-11 for morbidity in your setting or organization? It's one thing. The other is, what information or research will your organization need in order to inform assessments of cost, benefits, implementation approaches, communications, and outreach regarding the transition to ICD-11? What considerations affect the impact of ICD-11 on clinical documentation, payment processes, including risk adjustment, public health, population health, or research? Number 4, what unique U.S. coding or terminology considerations are essential? For example, coding or terminology related to community health, social determinants of health, essential human needs, sexual orientation, gender identity and expression, obesity, external causes of injury, and information about mental, behavioral, or neurodevelopmental disorders, including alignment with the DSM-5. Number 5, how should HHS implement ICD-11 in the US for morbidity coding? Number 6, the World Health Organization recommends establishing a national center for ICD-11 implementation. What entity should be responsible for coordinating overall national implementation of ICD-11 for morbidity coding, and how should the implementation be managed? Number 7, ICD-11 uses an open process in which the World Health Organization encourages requests for updates and changes, thus eliminating the main drivers of national clinical modifications. What entity should be responsible for coordinating U.S. requests for updates or changes to ICD-11? How should this process be managed? What resources, tools, or support will your organization need for implementation? What kinds of technical resources, guidance, or tools should the U.S. federal government make available? What workforce planning, or training will your organization need to support implementation? And what are your organization's requirements for ICD-11 mapping to other coding systems and terminologies, including value sets? And lastly, number 12, what other operational impacts of ICD-11 adoption and implementation should HHS consider? So these are some of the answers from those questions. So for the first one, they said enhance alignment and integration with EHR systems and with richer clinical terminology and vocabulary standards such as SNOMED. Increased ability to describe health conditions in greater detail through the combination of codes, facilitating research collaborations, clinical decision-making, accurate reimbursement, risk-adjusted quality measure reporting, value-based and care and payment, and efforts to improve equity by addressing social determinants of health. Someone said the transition to ICD-11 is likely to be more impactful than the transition of ICD-10 by shifting emphasis and capability to post-coordination. That means adding and joining codes to express detail across conceptual dimensions, and thereby introducing new flexibility and clinical precision. ICD-11 provides the flexibility and underlying structure to capture new discoveries in medicine, helping to streamline the code update process, support future expansions, and improve timely availability of data for use data for all use cases. One thing that they mentioned at the meeting was, so for whatever reason, ICD-11 is not just an extension of ICD-10. It's a total kind of haul of the code set. And a concern came up about, why are you doing these rehauls every time? and the response was that ICD-11 is kind of designed to stop those rehauls. And so they wanted to create something that this is it. And then when things need to be updated or added, there is an easier way to make those adjustments versus having to have this whole, okay, now we got a whole new platform or a whole new code set that we now need to transition to in order to use for diagnosing procedures, et cetera. And so that is why the discussion around clinical modification is so important, because we use the clinical modification piece for multiple reasons, but primarily the reimbursement piece. And that's why they're talking about this. Some information or research will your organization need? Again, decision on whether a U.S. clinical modification will be developed, and if not, how will U.S. specific coding needs be handled? A comprehensive understanding of the structural and content differences between ICD-10-CM and ICD-11. Information regarding whether HHS plans to provide publicly available mapping software that links its linearization and clinical modification of ICD-11 to ICD-10, CM, and PCS. More detailed information about the nature and scope of these changes, the pathway and transition between versions, requirements, if any, for EHR vendors, implementation of ICD-11, a detailed timeline with milestones and achievable benchmarks, clarity around changes in governance processes, including U.S. deviation from the World Health Organization, research around the benefits, the comprehensive cost benefit around the benefits and costs of adopting ICD-11, including the impact on payment, reimbursement, and new payment models such as value-based care, understanding impacts of ICD-11 implementation on other adopted code sets such as CPT, HCPCS, SNOMED, CT, and LOINC. LOINC, is that how you say that? Expected changes to administrative transactions and workflows, current data storage and transmission, etc. Expected software changes to accommodate ICD-11 in the electronic health record and practice management systems, and estimated vendor implementation timelines and costs. Results from case studies of pioneering ICD-11 installations. They really, really talked about that a lot. Like, well, what is the information that you're getting from those who have already, from countries who've already adopted ICD-11? And then expected costs for staff training and expected changes to data collection and reporting, including quality measures, value-based programs, clinical research, and other clinical programs. Need to relate. So the next question, what considerations affect the impact of ICD-11 on clinical documentation, payment processes, including risk adjustment, public health, population health, and research? Need to relate ICD-11 STEM and extension codes directly to fields in EHR, allowing users to add combinations of STEM and extension codes to track the detailed course of a patient's health status. Relate changes to diagnostic and therapeutic interventions, assess comparative risk adjustment clinical outcomes, and guide healthcare quality improvement initiatives. Updates to a version of the mandated X12 transactions. It's a lengthy, burdensome process that supports ICD-11 must be in place prior to the ICD-11 implementation, along with updates to applicable operating rules. Evaluation of whether the level of granularity of ICD-11 matches clinical, public health, or administrative needs, or whether additional modifications are needed. Consider extent to which ICD-11 coordinates with non-clinical national and state mandated information interoperability content standards. For example, coding used for social services coordination, public health case or surveillance reporting, or quality measures for health equity assessments. All ICD-11 coding specifications related to compliant and complete code generation, displaying, reporting, and billing will be needed to identify tools and platform needs. Need upgraded capabilities to efficiently generate the content creation and to provide the end user with optimal experience with ICD-11. ICD-11 must be implemented properly to better meet various needs, which means adopting and mandating a US version that is more capable than the World Health Organization's MMS alone. All systems and processes leveraging ICD-10 codes will need to be evaluated for impact on transitioning to ICD-11, payment systems, public health, social service entities, population health, and research. And will there be consistency across payers in the definitions as to a complete code? That is a great question. What level of post-coordination is necessary to adjudicate a claim? See, again, everybody's voice matters and everybody's perspective matters. Let's see, what unique US coding or terminology considerations are essential. Refine and augment existing social drivers of health and social needs codes to gather data in a standardized way across payers and providers, aligning when possible with the Gravity Project and US core data for interoperability. Consider concepts such as loneliness, lack of social support, military deployment, digital literacy, lack of internet access, and IPV. Current ICD-11 codes may be insufficient for osteopathic and chiropractic providers. Consider requirements and timelines of other mandated regulatory changes and updates, including interoperability standards, the No Surprises Act, HIPAA standards and operating rules, and TEFCA, etc. Updated versions of the mandated X12 transactions will be needed to accommodate all coding terminology considerations. If the US has unique ICD coding requirements that require either an extension or modification, will the US create its own type of URI to align to the World Health Organization's Foundation or MMS? Consider need for increased specificity in the area of rare diseases and genetic conditions, and consider governance model to coordinate coding solutions and consolidate terminologies used in clinical practice in US. For example, stages of diseases. How should HHS implement ICD-11 in the US for morbidity coding? Well, slowly and carefully was one response. Time frames from 2 years to 10 years. ICD-11 should be implemented only after a clear return on investment is established to show that there is value in using the updated code set for morbidity and that it outweighs the implementation cost. They should develop a detailed roadmap and transition plan with a phased approach. Coordination across all agencies and stakeholder groups is essential. Collaborate with key stakeholders, for example, providers, payers, public health, EHR, health information technology vendors, and professional associations to develop tailored implementation guidance and materials. Provide a comprehensive set of crosswalks or mappings with ICD-10, CM, SNOMED, CT, etc. Consider lessons from ICD-10 implementation, but what are they? Some advocate a hard cut from ICD-10 to ICD-11 based on date of service. Others advocate a transition period during which both code sets could be used. Oh my God, that would be a headache. Okay, I'm sorry. The mandated version of ICD-11 in the US should facilitate access to all entities, clinical concepts available in the ICD-11 Foundation, and national implementation must consideration, which linearization, I can't say that word, will be leveraged. Private efforts are underway to develop a U.S. tailored, again, that word, linearization building on MMS, but other linearization may be useful for specific specialties or setting, i.e., mental health. Okay, let me check in with you all, see where we are. If there are questions, concerns. No? Y'all just listening and getting all the tea, all the tea. Okay, it's cool. What entity should be responsible for coordinating overall national implementation of ICD-11 for morbidity coding? And what entity should be responsible for coordinating U.S. requests for updates or changes to ICD-11? And how should this process be managed? So some of the commenters express differing views. Some advocate traditional approach, relying on the National Center for Health Statistics with input from the cooperating parties, Office of National Coordinator, ONC, or the National Library of Medicine, CMS, etc. Some advocate enhanced role for the National Library of Medicine. They mentioned them a lot on the webinar. Office of Health Data Standards and Terminology, leveraging its role as National Release Center for SNOMED CT, but with input from other agencies and stakeholders. Some advocate advanced role for CMS, leveraging its role as primary regulator and user of coded data. Consider the creation of a national steering committee or task force with representatives from key stakeholders, including government agencies, professional associations, healthcare organizations, and academia to oversee the implementation process and address challenges, ensuring effective collaboration and representation of diverse perspectives. Structured and transparent process will be needed to align requests with global updates and support timely and clear versioning. And they ask, what tools, what resources, tools, or support will your organization need for implementation? What kind of technical resources, guidance, or tools should the U.S. federal government make available? Timely release of policy guidance, develop a specific ICD-11 FAQ section on the CMS website, along with other guidance and public and private sector resources, stakeholder-specific educational webinars, live and on demand, computer-based training, toolkits, training conferences and publications, regular review of industry readiness with an ICD-11 ombudsman at DHHS to address concerns, include an ICD-11 support component into ONC's electronic health record certification program, work collaboratively with industry organizations to develop and disseminate resources, a U.S.-specific browser, especially if the U.S. defines specific requirements of ICD-11 coding, such as for extension reporting, standards or coding guidelines around how specific features of ICD-11 should be used to ensure consistency, such as the use of extension codes, ICD-10-CM to ICD-11 and ICD-11 to ICD-10-CM maps, with NLM's HDST responsible for developing and disseminating the mappings, and consider special needs of physician practices, rural hospitals, Medicaid providers, and plans. They ask what other operational impacts of ICD-11 adoption and implementation should HHS consider. The wide-scale upheaval and significant costs that will occur with the implementation of ICD-11 needs to be closely considered along with expected benefits. HHS should consider other legislative and regulatory requirements and deadlines that will overlap with the implementation period of ICD-11. Healthcare providers have limited resources for updating their EHR and practice management systems, training staff, changing administrative workflows, and sustaining the loss of productivity through an implementation of this large scale. Careful coordination of various regulatory deadlines with changes requiring extensive data and/or IT updates should be considered. implementing an updated version of the mandated X12 transactions to a version that supports ICD-11 needs to happen before the implementation of ICD-11. Look at lessons learned from the ICD-10 implementation to identify best practices for use with ICD-11. HHS should consider the impact the adoption of ICD-11 would have on pharmacy industry, clinical laboratories, physician practices, rural hospitals, small health plans, etc., and provide support to ease the transition and ensure workforce readiness. Testing requires support, dissemination, learning, and feedback. And the concluding thoughts. The request for information published in the Federal Register launched robust discussion among the key stakeholders and helped set the agenda for the meeting they had in early August. The number and detail provided in comments was limited by the timeline for response. The general tenor of responses suggested cautious enthusiasm with a need for careful attention to many critical challenges, learning from ICD-10 implementation, more planning, research, testing, and evaluation are needed with involvement of all stakeholders. And another request for information cycle may be launched after this meeting, and they talked about that as well, with refined questions and a longer opportunity for response to engage more stakeholders. Because I think they only had like 19 responses. I don't think it was a whole lot. And I know when I got the information, and I think I shared it, it was like days before everything was due. So I think, yeah, they would need to get some more information and get folks out here in the world. Well, look at here. Let me stop sharing. Uh-oh. I'll hear all kinds of stuff. Wait a minute, let me mute over here.
Oh, that's what I tell you. Yeah.
Go ahead.
I am literally just rolling out the bed. I set my alarm clock. I really did. It was like 2 o'clock, and I'm like, oh, let me make sure my clock is set. I don't know what happened. Oh my God, I am so sorry.
You are fine. I thought the storms and the power outages got you, because I know there was a lot of that going on there.
But it didn't. Thank God.
Oh.
They drugged me last night. What happened?
Sorry, were you out there in them streets? Were you in them streets last night?
No, I wish. Because I was on set for this topic because you and I, we were around when they introduced ICD-10.
Yes.
And the mess that was.
Yes.
So, and I'm just like, when they say cautious enthusiasm, that's what I have, because I don't think it's going to go the way that they want it to go, because nothing ever does. And I just think that it's almost going to take an act of Congress like it did to get ICD 10 enforced. Because they kept kicking that can down the road, so Congress is like, no.
Like, stop. Like,
you can't do it.
Right. And then no sooner they got it done, here comes ICD-11. Oh, my bad. And no sooner they got it done, here comes ICD-11. And it's like, oh my God, you're going to take the same amount of time, the same amount of putting your heels in the sand to prevent it from coming. Like, get on board. But to their point, because we use this code set for so many different things, I understand the need. But let me just say this. I don't understand. I know it said that they started this conversation in 2019, but they started the conversation about ICD-11 years before that. So why are we not? Where's the U.S. when the IC in the World Health? Are we still members of the World Health? Let's start there. Like, are we still members? Or is somebody not listening when they start talking in the a meeting like this is going on? Because I think at some point, those conversations, we should be past this part. I feel like we should be way past this part in getting information. We should be at the part, where at least policies have been written, mandates, if necessary, have come down. All of that, like it's just now starting from scratch, like it's brand new. It's not in other countries. It's not brand new, sirs and ma'ams. Let's see. What Vicky says, they should first focus on real medicine and health and doing a revamp of the whole healthcare system instead of focusing on the codes and how to expand profit making through them. Well, true. I agree. True. But keep in mind that ICD-11 is not just for us, for the US. ICD-11 is a worldwide collection, because when you hear about the data related to diseases and trends and all of the things, morbidity and mortality is really what these codes were originally designed for. So you would get the statistical information about, you can pinpoint, okay, we're seeing a whole bunch of XY. For example, I hate to bring it up, but like with COVID, when they put those codes out for COVID, that's how they can trend and track. We're seeing an uptick of COVID in this area of the world. We're seeing an uptick because this was a consistent codes for COVID that you can easily follow across the world and do the contrast and comparison that was necessary worldwide. We just need, again, as I mentioned before, we special. And so we wanted to add, we felt like, I think at some point, somebody felt like years and years ago, well, we already got this code set. Why don't we put this in with the reimbursement mandate that they got to have a disease in order to get paid, and so on and so forth, and the ball roll? Well, ICD-11 or ICD-10 or ICD-9 without the clinical modification was never designed for that. And that's why the clinical modification came into play. But now they're trying to find a way to really, I think the World Organization is sick of the US. Like, y'all in this foolishness, stop. Y'all delaying these processes. We can't do the needed analysis worldwide because we waiting on y'all. I'm sure we're probably not the only one, but we're probably the biggest one. And like, we waiting on y'all. Come on. Stop playing. And so they're trying to figure out a way around this. And one way that they were talking about in the webinar was these extensions. So having like these extension codes, so it's not a full new code set. It's just like an extension to a companion manual, if you will, that will have like some extension, which is going to be a lot of work for those of us that use this manual. Likewise, I think putting both feet in both areas, trying to code it, that's going to be a nightmare in my opinion. That's just my opinion. Mr. Jesse, what's your thoughts? Let me mute.
Oh, it's definitely going to be a nightmare because we could just never go along with everybody else. We always have to come in and try to change something and make it our way. And it would be fine if we wanted to make things our way and we did it in a timely manner so that we could go along with everybody else. Okay, we're going to go along, but this is what we have going on over here. Okay, we all have decided this day we're going to roll it out. Okay, good. We're ready. We always wait until the last minute and then want to act like we had no idea this was going to happen. I mean, people don't realize there has been access to this code set for like what, 2 years now, a little more.
Yes, and I've told people, go out there, look at it, play with it, because it's different. It's totally different, and it's set up for the EHR world, pretty much. It's like database, and so it's set up for the ease of updating into those systems. But there's a method to the madness, if you will. However, you still need to understand how it all links together. And again, because we don't have the clinical modification that we're used to, you can still begin the process of understanding the foundation of it by just going out there and playing around with it and taking a look, because it's been out there for a minute.
The only thing I'm a little curious about it, what I'm wanting to see. I'm old school. I need a book.
Oh,
Because they're supposedly the beauty of ICD 11 is it's not going to need a book, and it's even bigger. There are way more codes than even ICD 10. So I need a book. That's all I'm saying.
I know, me. I write down everything. I'm writing as we speaking. I like validation. And so the book, while I can do and play around with the EHR and assign as needed, I need some black and white validation. And so I know in most of these, or probably all of these, because I haven't looked at every EHR in the world, but they do have the guidelines, and they have all the information in them. It's just a roundabout way of looking for stuff. Like, I'm tired of looking at computer screens. Can I please rest my weary eyes on a book? I think we're doing our health, our ocular health, a disservice by always looking at the screen. That's my own personal opinion. And they ain't gonna have braille on the screen when we go blind from looking at these screens all the time. So I don't know. I'm like you. I like a book, and hopefully, I know the book producers want a book too, because again, that's a win-win for them. Whatever. I like a book, and I remember. Oh my God, were you coding back when we had when I first started our ICD, well, because it was ICD 9 and we had ICD 9 forever. So you had this huge binder that was ICD 9, and it had all of it's like a 3-wing or 5-ring or whatever, but it was huge. And this is what you had to carry around. The updates, you didn't get a new book every year. You got a new packet of loose leaf documents that you had to physically go through that binder every year and replace the pages out. See, I know I sound like a dinosaur, don't I? Replace the pages out for the updates. And then I guess somebody somewhere was like, this is just utter foolishness. And they stopped that practice. And so, the publishers was like, yay, we got new books now. We can just update and do a new book. Go ahead.
I started in 2014. That was like the tail end.
Okay.
ICD 9.
Okay. Yeah. Oh my God. Yeah. We were in class, and you would see, they should have had rollers then in class, because Lord, we just lugging those books back and forth to class was a whole chore. That's probably how we stayed in shape. Books going up and down steps and all of the things. But then you would go into the hospitals and go into provider offices and everything, and you would see these massive, and it was just one, I want to say it was just one publisher of the book at that time, because everybody had that same. I wish I still had one of them. I know somebody who got a picture though. I'm gonna get a picture, and I'm gonna show it to y'all so y'all can see. She did. One of my board members a couple of years ago did like the history, or kind of a pictorial of where we've been in this profession. And I think she did it she used the books, and then also like looking at the files. So remember, we had the filing system and the terminal digit filing system, and see, I'm probably talking way over all y'all heads. But anyway, that was our world back in the day. And she did a presentation. I'm gonna look for that and see if I can or reach out to her and see if she can share with me. And I remember seeing that book, and I was like, baby, where'd you get that picture from? But she had that picture. Oh, yeah. So that was the whole tea. Now, you missed my church announcement. And I told you I had something special, and I was going to make you wait until the replay, but I'll show you what it was. So you know I like to be creative, but ours got a little twist. I told you I was so excited. I was like, I know what I can do. Looking for what I'll create my own. And there we go.
I've got to get one. I'm going to find me somebody's services to go to.
Well, I'll send one. I'll make another one and send it to you. So you can have it. Oh, I'm muted over here. Okay. I said I'll make another one and send it to you so you can have it when you go and reach out to the people. All right. So that was clinical ICD 11, clinical modification or not. Now, the other thing was, and this is what I mentioned last week. One of those people on that work group, and I think I saw it in one of these, because there were several presentations, and I wasn't going to bring you all the presentations, but in the description link is the actual information about the meeting. And there's even the webinar, the replay, all of that. So all of the things you have access to. So it's in the description of this video. But one of those providers was lightweight because there was some AI discussion related to this and how AI can assist in accurately coding ICD 11 using this new format. And so that's where we had a lot of discussion around that and what was happening. Oh, you're welcome. She said that's cute. What was happening around that. So more to come on that because yeah, the way he came was trying to replace the coding function using AI. And, again, my ears perked up like, whoa, wait, what'd you just say? So yeah, more to come and see where I didn't see any comment from the request for information on there, but there was comment in the actual meeting, and they did breakout groups to further discuss some of these things and how to approach and talk to stakeholders and to figure out like where the money is supposed to come from. And I know there was a lot of conversation and discussion, like the government needs to fund this. Y'all want us to have this, y'all need to fund this. So more discussion on all of this. And as I get information, I will definitely bring you the tea and bring you the information so that you can get involved. And like I said, they are really, really strongly considering doing another RFI and lengthening the time that the information is going to be the time that you can turn the information back in. And again, you are part of using this code set. So you are a stakeholder. And you individually, you don't necessarily have to provide information as a member of XYZ organization. You individual coder, you individual biller, you individual person who deals with this code set has a voice. So if you want to provide information, by all means, send your information in. And again, I'll let you know when the next RFI comes out. Ms. Jessie.
I really do think that people need to get involved because if HIM is any indication of the people who are going to be implementing or overseeing the implementation of this, people mess up regular everyday coding and the regular processes. So I can imagine how, if we don't get involved and give them our feedback, it'll just become a runaway train. And we really do have to let our voices be heard about what it is we want and what we don't want. We really do.
You are absolutely correct in that. And like I said, even reading some of these comments, there were positions or vantage points that I hadn't even considered. Like, oh, well, who knew about that? Or, how that would impact some of the additional initiatives that they have going on, or the additional specialties that require information from the ICD 10, 11, whomever code set. So you never know, something that you may have to add may, be an aha moment for someone to consider when going forward. And yeah, and I think they also, and they mentioned it before, also need to consider how this will impact various stakeholders. Not, you can't just look at large organization all the way down to the one provider shop. They need to understand and know how this impacts them. And imagine the cost to a one person provider in this whole implementation. So finding, I think a government incentive may be a good thing, but who knows? Yes. Well, the AI, she said, learning how to write AI commands, the prompts. So there are several different, I've followed several different people who have kind of searched or put together a collection of prompts for various AI systems. I haven't really seen a health. Maybe I need to look. Yeah, that's where I was going with that. She's like, from a coder standpoint, I haven't really seen anybody doing a health or coder, health information revenue cycle coder prompting. Maybe I need to look. Maybe I need to play around and see what I can figure out, just to see what comes up as it relates to that. That's a good idea. But I haven't seen anything. But that would definitely be something that they would need to provide for folks if AI is well, when AI becomes a part of it. Oh, you got something. Oh, yeah, send me that. Oh, yeah, I've done all kinds. She said she wrote an appeal letter in ChatGPT. I've done all kinds of stuff in ChatGPT. ChatGPT has become my office assistant, whether y'all know this or not. It's become my friend. Here, I'll let you talk. Go ahead.
No, we do understand that we cannot. Progress is going to progress. We know that, but I just think that when it comes to HIM, it's far more nuanced than that. I think is beyond the scope of current AI, because they have been trying. Like we know they have been trying to have AI, take over coding for years, and it's just not. At this point, eventually it will get to a point because everything improves, all technology improves, but it's just not there yet. Because there's so many twists and turns, and this goes with that, and that's like our team had a presentation yesterday at work, and they wanted me, of course, to do the coding part. So I did diabetes causal relationships and hypertensive causal relationships. And when I showed them the actual tabular index screenshot, because they don't. Most of them aren't coders, so they have no.
They ain't never seen that before. They don't know nothing about that. It was a foreign language.
So when I showed them in black and white, I had a slide about unspecified CKD. In the tabular index under E11.22, it does not say that you can code unspecified CKD. Then I had I12.9 right under so they can see. Well, see right here with hypertension, you can code unspecified CKD. Well, you'd have thought I told them your mama joke.
Oh my God. Absolutely. And to your point, I don't think it's ready. One of the limitations that I think all of like the current AI free ones, let me just talk about the free ones out here that the common folks have access to. It's not current. It's not like today's information. So you really, and that's why prompting is so important, because you really have to be specific, or feed it the information that you want it to draw from. Go ahead.
Because that was the point I was getting into, because we have AI suggested codes, and currently in the system, the system links unspecified CKD and DM. It comes up as E11.2, and I told him, I said, you cannot do it because that's not compliant code. So I was just bringing that up, talk about how people are relying on AI, and it's just not there yet.
Yeah. But again, we have opportunities. We got information. We got the ICD 11, the global code set. We have some of these free AI resources at our disposal. I know time is tight, but maybe, one day when we not as busy as we are, maybe there's an opportunity there to just, let's see what I can find, or how can I play with? Because you never know. You may be the person that cracked that code. You may be the person that says, oh, okay, well, this, that, and the third, and put things together. I mean, I don't know. Maybe we could do something like that on one of our, maybe we could do something like that on one of our little things. Go ahead.
It could certainly happen, but I think right now the problem is there is no collaboration. You have people over here saying, "Oh, look what I created," and then they try to bring it in over here. Okay, well, you can apply it over there. But what needs to happen, and I think that it won't really get where it needs to get until both people are in the same room sitting down at the same time. This is what we need, and you create something based on what it is we need, rather than you creating something and then trying to make it fit. It has to be very specific.
And for the global, I'm just saying, for us to kind of get a feel for an understanding and look at it. But from the global perspective, and you will also need to have the regulators and the guidance, because we can be pulling, or the people can be sitting together saying, this is what it can do, and this is what I need, and this is what we can do, and this is what we need. But until they have the guidance surrounding it and what it looks like, it's not going, yeah. It's not going, they need that additional piece. There was something else I was supposed to do. I was supposed to tell y'all. I'll wait till next week. I know what it is now. It just hit me like, oh, that was supposed to be, but we'll talk about that. We're going to talk about compliance next week. We go, sir, don't you do that. Do not do that. Now, let me just say, compliance staff is under, there's not enough compliance staff, and their departments are underfunded, and they have to fight tooth and nail oftentimes, even with large organizations, just to get enough bodies to do the work that they need to have done. But again, there's some ways around that, and we can talk about that next week. So we're going to talk a little bit about compliance and the role of compliance in the role of compliance in revenue cycle processes. Go ahead.
I am so glad that you said that, because last night I was on, I want to say it was TikTok. Why was there a nurse talking about nurses should move into compliance?
Yeah, I'm trying to do. Sorry.
To get away from the bedside, but can I tell you, chickadee didn't say a word. Didn't say a word about nothing that you would need to know to be effective at compliance. They mentioned one stitch.
Oh my God.
Code knowledge, regulations. I'm like, oh, okay. We know.
First of all, I know You all nurse clinicians think y'all can do everything from walk on the moon to communicate with other beings. However, Lord Jesus, there's just like in health information, medical coding, all of the things, there are rules, regs, and you got to have a whole special kind of love for compliance. Let me just say this. It's a whole different type of, if you don't have the stomach for coding and health information, Lord, what do you think you're gonna do with compliance? She said, and gatekeeping. She said compliance is a foreign word to them folks, and gatekeep everything. Stay over there, please, and thank you. Yes, stay over there. Now, I know you probably done looked at some charts and provided some feedback and did some auditing of some charts, quality reviews. I'll give you some reviews. You've done some reviews and all of those things. That's not the same as compliance. Jesus Lord. Okay, here we go. Yeah, we're gonna talk compliance next week. Go ahead. Oh, go ahead.
When I saw it, I'm like, even I was like, y'all gonna mess up. Y'all gonna make it worse because it's bad enough trying to fight these people. Then you're gonna come in there with your little clinical background and think that no. And I'm like, here it is yet again, another group of people AIM is gonna have to educate and bring them along. No. Go find something else to do. Go do the whole legal nurse consultant thing that was always that never was really going to work anyway. Because the thing is, you have to put skin in the game. If you want to leave nursing, go back to school, learn something. Don't come and try to create something. Because like the whole legal nurse consultant thing, go be a paralegal. Go to school for that. You think you can take some little weekend course and all of a sudden you're in a whole new profession? No. No.
I think they believe that their core profession is the foundation and everything can be built upon that. And that's just not. There are other, just like with any profession, there are other terminologies, there are other nuances, there are other things that you have to learn. Yeah, it's great that you have a clinical foundation. Wonderful. Most of us who are working in healthcare do. We understand it too. We just didn't do the bedside part. However, you have to learn the other things. You have to learn and be able to speak the language. It's a whole different language over here in compliance. Yeah, we deal with clinical, but it's a whole other world, because you gotta consider, especially like regulatory, you got to be able to understand what they're saying as far as these rules. You have to, it's a whole lot. And again, it's not for the faint at heart. And you have to have, you have to love it. You have to enjoy it. It has to be something, that you enjoy and want to do. You can't just, like y'all say, flip flop into one versus the other because, I don't want to do this no more. Da 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 da. No. Oh my God, they about to muddy up our world over here too. Jesus. Everywhere I go, here y'all come. Go ahead.
I feel the same way. I'm like, and
wait a minute. Mummy Picasso said, "Why are nurses notorious for this?" Right, exactly. Why?
And the thing is, they make it sound like it's so easy. All you gotta do is this. Oh, have you considered? No, not that easy.
Lord, bless their heart. And they're not necessarily looking for like certification in it. They just feel like they can just take it and run. Come on, people.
Exactly.
Good morning, Beja Mac. Good morning. Good morning. All right. So this has been good. I'm sorry you overslept, sir. You are absolutely right. She says compliance is like continuously swimming against the grain. Be careful what you ask for. But I love it. I love it too. And yes, you talk about being the ones that everybody looking at like, here she comes. There's no love over here in these compliance streets. Trust and believe. Folks are not, they be like, no. They be trying to have closed door meetings and don't let you know nothing. And then they try to start stuff and then they need you. Like, oh, well, wait a minute. We did XYZ and now we got issues. This is not the love fest that you think it is. Go ahead, sir.
I've had several positions where I've been. One time I was a coder and compliance auditor for this company. Then another one, I was CDI. Listen, when you want to talk about being unfavorable, look, I was always the one. I was good for one meeting. I would be involved in one meeting, and then when I told them like that's not how this works, no more. I didn't get invited to any more meetings. Here I was supposed to be the compliance and code and compliance officer for a person, and you got a coder sitting at the meeting coming to tell me what they talked about in the meeting. I wasn't in it.
Yeah, all your invites to the party cease. They think they like the idea of it. They like the idea of it to put it on paper that you attended and you was there. So, which is also funny because they'll be like, well, compliance stamp. No, the hell we did not. No. Read the full minutes. And then your invites stop coming. I mean, you gotta love us. You gotta love us. But a good compliance person will assist you in trying to find ways in order to do whatever it is that you're trying to do compliantly, if there is a way. Now, a good compliance officer will do that. And they won't just always be like, absolutely not. But there are those instances where this is all we got, partner. And this is all you can do. She said, and I come strapped every time. Big guns, black and white. You tell me what your interpretation is. Oh, okay, carry on. Yes. Yeah, so that'll be, did you want to say something? I done muted so you could say.
I tell you, this is going to be, I'm already ready. This is going to be interesting next Saturday because compliance is the redheaded stepchild of the industry, and nobody really talks about it. And the reason why, and I'm going to say, compliance takes a hit the same way coding takes a hit because you have to have the right kind of person. And there comes a time when you have to say, because my phrase is, this is not how any of this works. I love that. Because they have no clue.
None.
And I'm telling you from experience, I worked two places that ended up getting sued by CMS because I told them this is not how it works. You can't do this. And they was dismissive. I'm like, okay, well, you carry on.
And trust and believe, even your organization, our organizations, I have not met an organization that hasn't had to have some sort of repayment, haven't had to have some sort of guidance, haven't had to have some sort of involvement, period. Whether government or commercial, where they're like, ma'am, sir, hello, no. This is no. Let's have a conversation. Let's talk. Let's revamp your thought process and training and the claims that you are submitting to us. So yeah, nope. So that's gonna be fun. Okay, we don't went over time. But yeah, it's gonna be a doozy. Wait a minute, am I missing some comments over here? Let's see. Most people dismiss what they refuse to understand. Amen. That should be a t-shirt. So true. Okay. And she said, see, that's the part right there. Now I got receipts. I'm not just gonna be a sitting duck for CMS, but y'all can absolutely. I tell folks all the time, here's the box. You can go close to that edge if you want to, but once you cross over, you done crossed over and you on your own. You on your own. All right. Well, this has been the Saturday Morning Tea. And thank you all for joining us. We even let folks come in a little later. I'm messing. um, so thanks for joining or checking out the replay. What's the tea spilled today? I hope this was information that was valuable for you. When I first put it together, I was like, they're going to be like, what in the world? But you need to know, you need to be prepared for the stuff and the information that's coming down. So I hope this was valuable to you. And this is something that you would feel others may need to know. So share the information, share the video, subscribe to the channel, do all of the things. I still have a 10,000 subscriber goal. I need y'all to help me get there. Help me get there. Tell people, I know you over there watching them YouTube videos. Here's my friend. Click her. Here's my other friend. Click him. Click us all. Be sure to follow us for more information on all things revenue cycle, health information, compliance, and medical coding. And as you leave out, don't forget to hit the thumbs up or like button. And also check out the Coding Nurse channel on YouTube. He drops some gems over there as well. Mr. Jesse, do you have any parting words?
Well, my first parting words, I apologize for being tardy to the party. But it was good. What I caught, and I'm telling you, next week is going to be even better. I can't wait.
Right, I'm gonna take a whole day to prepare. Look, I'm gonna take a whole day to prepare all of my thoughts on my profession compliance. Oh, because I love it. Okay, and then I'm probably gonna do some additional research to find out what in the world are these nurses talking about. It's they lying. But anyway. And anything that you can find, share that information with me. We will definitely have a robust discussion next week. So again, this has been a great session today. Thank you all for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care, be safe, and talk with you soon.